Good morning. I am presenting case of 52-year-old lady presenting with chief complaint of progressively increasing left breast lump since 2 months. Lump was noticed by her while taking bath. Lump initially was size of grape, but it progressed within 2 months to its present size, which is around size of a ball. Lump was painless throughout its course. Patient had no other presenting complaints. No history of back pain, abdominal pain or heaviness, cough, breathlessness, chest pain. No past history of any significant illness or surgery or trauma. No family history of any significant illness except that her husband is treated for tuberculosis of chest 5 years back. Patient is postmenopausal since 4 years. She has never taken any hormone replacement therapy or oral contraceptive pills. She had menarche at around 13 years of age and attained menopause at 48 years of age. She has 3 children and all were breastfed. Patient is vegetarian, not tobacco user, non-alcoholic.
A painless lump. What is your probable diagnosis based on history?
Based on history, my provisional diagnosis is malignancy left breast.
Your reasons?
As a rule, any lump in postmenopausal woman must be considered to be breast cancer, unless proven otherwise.
Lump was painless. If patient complained of mild pain and lump, would you still go with cancer as your provisional diagnosis?
Sometimes, in around 4% of cases, breast cancer may have pain, so I will still go with cancer as first diagnosis unless pain is acute and severe, in which case I might go other benign causes.
Benign causes, like what?
Breast abscess, hematoma.
Is this usual age for breast abscess?
Breast abscess usually presents in lactating females where milk in ducts provides good media for bacterial proliferation and sucking infants' oral cavity provides necessary bacteria.
You asked about back pain, abdominal pain or heaviness, cough, breathlessness and chest pain. Why these questions?
Since I suspected breast cancer, therefore it is important to ask for symptoms that might suggest metastasis. 3 most common sites of metastasis in breast cancer are lung, liver and bones.
For bone mets, you specifically asked back pain. Why vertebral mets are common in breast cancer?
Vertebral mets are common in breast cancer as posterior intercostal veins draining breast drains into perivertebral plexus called Batson's plexus.
Why did you ask about trauma to breast?
Trauma to breast can cause traumatic fat necrosis.
Why lump is formed in trauma?
Due to trauma, there is hematoma and fat necrosis, followed by calcium deposition leading to hardening of area.
Why lump in this patient unlikely to be traumatic fat necrosis?
Because of short history and fast progression.
What is importance of menstrual and obstetric history in breast lump patients?
There are certain menstrual and obstetric risk factors which increase lifetime risk of cancer breast, like early menarche, late menopause, nulliparity, OCP and HRT intake, no breastfeeding. Lifetime exposure to estrogen is important. Hence, if there is early menarche or late menopause, then years of exposure to estrogen is increased as menstruating women has high levels of estrogen.
How is childbirth protective?
During pregnancy, progesterone level rises. Progesterone is protective against breast cancer. Hence, more the progesterone, more the protection.
Is there any protection against cancer breast if abortion occurs?
No, abortion is not protective.
Why? There is pregnancy.
Probably because duration of progesterone exposure is less.
Why is breastfeeding protective? It leads to breast enlargement.
Breastfeeding increases differentiation of immature cells, hence protective.
Is family history of breast cancer important in this case?
Family history is important, but in cancer breast, development of cancer breast after 40 years is less likely to have genetic predisposition and is more due to environmental risk factors.
Okay, proceed to local examination.
Patient was examined in a well-lit room, in presence of female chaperone, with consent from patient taken for examination. Patient was examined in sitting, forward position, 45-degree propped up. On inspection, in sitting position, left breast appears enlarged as compared to right breast. Nipple of left breast is at lower level than right breast. Skin over both breast is normal. No visible edema. No nipple retraction present on both sides. Both areola are normal. No redness or crusting. A fullness is present in upper half of left breast as compared to right breast. There is no fullness in bilateral axilla and supraclavicular fossa. On raising both arms, there is nipple retraction in left breast. On forward bending, both breasts fall away from chest wall. On palpation, in 45-degree propped up position, right breast is normal on palpation. A lump is present in left breast, 5 by 6 cm in size, in left upper inner quadrant and central area. Lump is well defined, firm in consistency, nodular surface, mobile, not tender. There is no fixity of skin to lump. There is no dimpling of skin on moving the lump within breast. Lump is not adhered to pectoralis muscle. There is no edema visible on pinching the skin over breast. Right axilla is normal. 2 nodes are palpable in left axilla and central group. Both nodes are around 2 cm in size, mobile, not tender, not involving skin. Left and right supraclavicular fossa is empty. There is no upper limb edema on both sides.
Which is the best position to palpate breast for lump?
45-degree propped up. In supine position, breasts tend to fall sideways, and in erect posture they tend to move away from chest wall. As lumps are palpated against chest wall, so small lump may be missed.
Why is there nipple retraction in left breast on raising both arms?
This is due to involvement of ducts, which is pulled by tumor when breast moves due to arm movement.
How did you check for fixity of skin with tumor?
By pinching the skin above the lump.
What is this skin edema called?
It is called peau d'orange. It is French word meaning skin of an orange. Peau means skin, d'orange means of orange.
Why it happens?
Due to skin edema caused by lymphatic obstruction due to tumor cells in lymphatic vessels, thickening and elevation of the skin around tethered hair follicles and sweat gland leads to picture-like orange skin with fine multiple pits.
What are the fixity of lump you check in case of suspected breast cancer?
We check for 4 fixity. Fixity to skin, chest wall, pectoralis and breast tissue.
We discussed skin fixity. How would check rest of them?
If lump is mobile, then it is not fixed to chest wall. On asking patient to put both hands over pelvis and push down, pectoralis major will get taut, and this should be checked by palpating anterior axillary fold, which is formed by pec major. Any restriction in mobility of lump after muscle is taut, especially in direction of fibers, signifies pectoralis adherence. On holding breast flat by one hand and moving lump with another, there will be dimpling of skin due to movement of lump as cancer invades normal breast tissue and drags it along with it.
What are the different groups of lymph nodes in axilla?
Anterior group behind anterior axillary fold, posterior group in front of posterior axillary fold, central group against chest wall, medially lateral group against upper end of humerus, apical group in deep apex of axilla.
Is axilla examined from front or back?
Posterior group is examined from back, rest from front.
While examining left axilla from right hand, where will you put your left hand? On patient's right shoulder or left?
On ipsilateral left shoulder. By left hand I will lightly press the left shoulder of patient because, during palpation of axilla, patient may shrug her shoulder, making it difficult to palpate.
What is diagnosis?
My diagnosis is carcinoma left breast, clinical stage CT3N1MX.
Why MX?
Because I have not investigated for metastasis.
But this is clinical stage based on history and examination. If you have not found any sign or symptom suggestive of mets, then it is clinical M0. Clinical MX means you have not assessed the patient. You must not use carcinoma as it is histological term. Just say malignancy left breast. How will you proceed?
As per triple assessment, I have done clinical examination. Now I will do radiological and pathological workup. In radiology, I will do X-ray mammogram.
Unilateral or bilateral?
Bilateral, to exclude synchronous second primary in other breast.
Is there any role of MRI in this case?
No, MRI is more helpful in young patients where increased density of breasts decreases sensitivity of mammogram.
In which cases would you not go for mammogram?
In cases where there is fungating tumor, very painful breast or large tumor.
Which view is commonly used in mammogram?
Mediolateral oblique and craniocaudal.
Why mediolateral oblique, not mediolateral?
Because in mediolateral view axillary tail of breast is missed.
What are categories in which you place mammography, based on risk of malignancy?
By RADS, Breast Imaging Reporting and Data System. It is risk assessment and quality assurance tool developed by American College of Radiology.
What category is expected in this patient?
By RADS 4 suspicious or by RADS 5 highly suggestive.
Any role of ultrasound in this case?
Some radiologists may use ultrasound as adjunct to mammogram before making final report.
After radiology?
I will do biopsy of this lesion.
Which biopsy?
Core cut biopsy.
How do you do core cut biopsy?
By specialized instrument called core cut gun.
Why not FNAC?
Because FNAC cannot differentiate between in situ and invasive tumor. FNAC cannot give additional information about tumor like histology, differentiation, hormone receptor status, HER2 status, Ki67.
Can this case be in situ tumor?
Since this case has lymph nodes involved, so it is invasive cancer or in situ cancer with invasive component. However, I will get FNAC from lymph nodes.
Please go ahead.
After triple assessment, when diagnosis is confirmed, I will proceed with metastatic workup. Since this is locally advanced case, I will do CT scan of abdomen and thorax with bone scan for bone mets.
And PET scan?
PET scan can also be done, instead of CT and bone scan, if availability and affordability is not a problem.
Suppose this patient's MET's workup is negative and FNAC of nodes is positive and biopsy turns out to be positive for malignancy. How will you proceed?
I would like to know about patient's receptor and HER2 status.
Which receptors?
Estrogen and progesterone receptors on breast cancer tissue.
What is HER2 status?
There is HER2 new gene which produces HER2 protein. HER2 positive means either there is HER2 new gene amplification or HER2 protein overexpression.
In HER2 report, you will see 1+, 2+, and 3+. What are these?
1+, 2+, 3+, a grading of HER2 gene amplification and HER2 protein overexpression on immunohistochemistry. 1+ means HER2 negative, 3+ means HER2 positive, 2+ indeterminate. In 2+, we will get FISH, fluorescence in situ hybridization, test to confirm HER2 status.
Okay, so how will you treat this patient?
Since this patient is locally advanced breast cancer, hence I will start treatment with neoadjuvant treatment for downstaging, followed by surgery, followed by adjuvant treatment. In adjuvant treatment, this patient will require adjuvant radiation, adjuvant chemotherapy, if full course of chemo is not given in pre-op. Then this patient will require hormone therapy if she is positive for ER, PR receptor and anti-HER2 therapy if HER2 is positive. Anti-HER2 therapy may even be given in neoadjuvant setting to achieve maximal downstaging.
Is there any classification of breast cancer based on hormone receptor status and HER2 status?
Breast cancer is divided in 4 categories based on hormone receptor expression, HER2 status and Ki67. Luminal A is hormone positive HER2 negative with low Ki67. Luminal B is hormone positive HER2 negative but with high Ki67. HER2 enriched are tumors with HER2 new positivity, hormone may be positive or negative. Fourth group is triple negative or basal type.
Which has best prognosis?
Luminal A.
What is PCR?
It is pathological complete response. It happens due to complete disappearance of tumor in breast and axilla by neoadjuvant treatment. It is achieved in around 25% of cases and is associated with improved survival. Therefore, every attempt must be made to achieve PCR by aggressive neoadjuvant treatment.
Which tumors are more likely to undergo PCR?
Tumors which are aggressive and have higher proliferation rate are more likely to achieve PCR like triple-negative breast cancer and HER2-enriched cancer.
Which type of breast cancer is least likely to undergo PCR?
Luminal A, as proliferation rate is slow.
How many cycles of chemo are given?
Around 6 to 8 cycles are given, preferably sequential taxane and anthracycline-based regime. All can be given in neoadjuvant or divided before and after surgery. This is sandwich regime.
What precaution will you take when giving Herceptin with chemo?
Herceptin is not given along with anthracycline as both have common side effect on heart. However, taxane can be given with Herceptin.
What surgery will you plan in this case after completion of demo?
I will plan modified radical mastectomy.
Why not breast conserving surgery?
Since this is locally advanced cancer, my preference is modified radical mastectomy. However, BCS can be attempted in selected few patients where there is excellent response to chemo and patient is willing.
If patient wants BCS and tumor is not palpable after chemo, how will you locate tumor bed accurately?
When neoadjuvant chemo is started, I will place radioactive clips or metallic clips in tumor, so that in case there is good response, I can still locate original tumor bed for excision.
If you are planning for MRM, would you still go for clip placement before chemo?
Yes, even if MRM is planned, I would still place clips in tumor so that in event of complete response, pathologists can locate original tumor bed for detailed microscopic evaluation.
What if tumor progresses during neoadjuvant chemotherapy?
Switching to another first-line chemo, taxane to anthracycline and vice versa.
Despite changing drug, if progression occurs,
then switch to second-line chemo drug, or if lesion is resectable then do MRM. If lesion is inoperable and non-responsive to chemo, then a trial of neoadjuvant radiation can be given.
If tumor is hormone positive, when will you start hormonal drug?
After completion of adjuvant treatment.
Which hormonal drug?
Since patient is postmenopausal, so I will start aromatase inhibitor.
For how much duration?
5 years.
What are the main side effects of AI?
Myalgia.
Can we give tamoxifen?
Yes, tamoxifen can also be given if there are both options and contraindications to none, then AI is preferred.
So what is contraindication of AI?
Severe osteoporosis.
Can we give hormonal with chemo?
No, it's not advised as hormonal drug slows proliferation rate while chemo acts on rapidly dividing cells, hence effectiveness of chemo may decrease.
What will be the duration of Herceptin?
It is given for 1 year, either weekly or 3 weekly.
What are indications of post-mastectomy radiation?
More than 5 cm tumor, node positive, close or positive margins, at risk axilla like an incomplete axillary dissection or extranodal spread in axillary nodes.
What fields are radiated in post-mastectomy radiation?
5 fields: chest wall, infraclavicular, supraclavicular, internal mammary, at risk axilla.
Concepts of Oncology, a channel dedicated to teaching about various cancers. Extremely useful for medical students for exams. Visit the given link.